Hello, thank you so much for having me. My name is Brinda Kamdar, and I'm one of the regional acute pain anesthesiologists at Mass General. And I'm going to spend the next about 30 minutes providing an introduction to neuraxial ultrasound. I personally find pre-procedural ultrasound to be an underutilized but incredibly useful tool. And I'm really hopeful to shed a little bit of light on the subject. I have no disclosures. So a few of the things I'm going to talk about today. So I'm going to praise some of the evidence for the use of neuraxial ultrasound. I'm going to go over a little bit of the anatomy of the neuraxes and identify some anatomical landmarks as well as the ultrasound correlates. And then I'm just going to go over how to actually do this in real time. So sort of outline an approach to actually delivering neuraxial anesthesia with ultrasound. So the question is really, why use ultrasound? You know, most of the procedures we do are pretty straightforward. So I want to just outline a few of the reasons, some of the pros as far as using ultrasound on a regular basis. So first of all, it's pretty non-invasive and safe. So really no downsides as far as the use of ultrasound. It can forecast difficult epidurals. It's a great teaching and learning tool. And interestingly, I've really found that as I've developed proficiency in neuraxial ultrasound, my success rate with landmark-based approaches has really improved. It can also help in selecting the best needle suited for the procedure. And it improves the success rate of epidural placement on first attempt. And there's actually quite a bit of data about this. It can also improve patient comfort and satisfaction. And I definitely find that when I tell patients that I'll be using pre-procedure ultrasound, especially those who have had really poor experiences in the past, they're nothing but relieved and grateful. So as far as some of the evidence, so the use of palpation-based approaches to determine intervertebral levels are largely unreliable. And this is really the first point I want to highlight. So landmark-based approaches traditionally involve palpating the superior aspect of the iliac crest with the assumption that this correlates to the intercristal or tough ears line, which I think we all know is a transverse line, which radiologically most often crosses the vertebral body of L4 or L4-L5 interspace. However, multiple studies have deemed that palpation is an inaccurate surrogate. So in a study that Margarito performed, in 45 pregnant women, was determined that the palpated intercristal line was located above L4, L5 in 100% of women and above L2-3 in 35% of women. Similarly, Broadbent and his group assessed anesthetist's ability to correctly identify an interspace by surface landmarks using MRI as a gold standard and found essentially that the correct interspace was only identified 29% of the time. And I think more interestingly, the conus medullaris in 19% of patients was terminated actually below L1. And so I think, implications of this, for inappropriately placed spinal anesthetics at levels higher than desired, levels include neurologic trauma to the spinal cord, as well as ineffective analgesia, such as sacral sparing during the second stage of labor. Other data, there's very consistent data that neuraxial ultrasound identifies lumbar intervertebral levels with much greater accuracy than landmark-based approaches. So in a study performed by Furness, where essentially accuracy of neuraxial ultrasound was assessed using spine x-rays, ultrasound correctly identified the L3, L4 intervertebral level about 71% of the time, whereas palpation was only 29%. And importantly, ultrasound was only inaccurate by one level, higher or lower, whereas about 30% of palpation assessments were inaccurate by more than one level, usually higher. And I think this number of 71%, it's important to understand that there have been studies that with appropriate neuraxial ultrasound training and education, interspace identification accuracy has been shown to improve to upwards of 90%. So other benefits, there's significant data to suggest that ultrasound improves precision and efficacy by decreasing the risk of technical failure and the number of needle punctures required, both in patients with normal surface anatomy as well as those at risk of difficult insertion due to obesity or scoliosis or prior spine surgery. And that was in a meta-analysis performed by Dr. Perles and group. And furthermore, there's a really good correlation, like within 3 millimeters, between ultrasound measured depth and the actual insertion depth. So spinal ultrasound is challenging. I think it's just important to just put that out there. And so, why is this and why is it difficult? So one reason is that the structures we're imaging are sort of housed in this very complex articulated encasement of bones, which really affords very limited acoustic windows for the ultrasound beam. Also, the structures are a lot deeper than we're accustomed to, compared to, let's say, central line placements or peripheral nerve blocks, which are only a couple centimeters under the skin. Also, I think this can be one of the more frustrating parts. There are a lot of factors like a change in the patient position between the skin marking and needle placement, misestimation of the middle of the probe, the need to really memorize the probe angle and mimic that same angle for needle placement. That can all lead to minor inaccuracies. And, the thing with neuraxial ultrasound, it's important to remember that due to the depth of the neuraxial structures, any small change in skin markings or changes in the angle of insertion can lead to really exaggerated changes to the final position of the needle. So really meticulous care needs to be taken during the skin markings. Otherwise, it can really lead to an unsuccessful block. So as far as equipment, so we really only need a couple of things. Low frequency probe, so it's really preferred to provide enhanced beam penetration as well as sort of a wider field of view, and useful for deeper structures, gel and a pen. As far as a linear probe, the higher frequency linear probe, very difficult as far as using it in an average size adult, but can be certainly useful in the pediatric population because the shorter distance from the skin to the neuraxes, as well as sort of limited ossification in pediatrics, in the pediatric population, especially in infants. So once in a great while in a thin elderly patient, I'll consider a linear probe because of the lack of the contact to the skin. So that's potentially one you'd use for it. So as far as vertebral anatomy, so this is essentially a cross section. So we have a superior and a posterior view of L3-4. So I'm just going to go over a couple of structures here and point out many of these you guys are very familiar with. So of course, this is spinous process, more or less short and sturdy compared with longer and more oblique thoracic spinous processes. Here, of course, is the transverse process. And it's important to just note that the transverse process is sort of on the superior aspect of the vertebral body, not directly in the middle. Here we have lamina. So on the lumbar area, and we're going to focus on lumbar today, the lamina is not, it's important to realize that the lamina is not flat. The lamina is sloped like a slide. And you're going to see how, on ultrasound, you can pick up on that. This is, of course, a facet. Facet joint is made up of two processes, superior articular process, as well as the inferior articular process. And here we have the pedicle, which sort of joins the vertebral body and the vertebral arch. And here, of course, we have our vertebral foramen and our vertebral body. This space is more of an ultrasound lingo. We're gonna call this an interlaminar space. And I'm gonna mention that in some upcoming slides. So here's a cross-section essentially of the cervical spine, and we're not going to be talking too much about, and I don't think many people are doing too much cervical ultrasound, but the reason I'm using this image is just because of the how clear the image is as far as the pictures here. So I want to just review from posterior to anterior some of the structures that we're going to be encountering. So the first layer here, this red, that's our ligamentum flavum. And as you go more anterior, you're of course going to have your epidural space. But I think it's really important to notice that the epidural space is not just, even though we traditionally with landmark-based techniques focus on the posterior epidural space, the epidural space actually, it comes all the way around the spinal cord. So you're going to see it over here, and then you're going to see it in here. So posterior epidural space, followed by posterior dura mater, and dura mater also goes sort of all the way toward the anterior side, so you're going to see the anterior dura mater shortly here. Next, this is followed by subarachnoid space, and here we have our anterior dura mater, and we have anterior, essentially epidural space, which is sort of, there are some lateral crevices here that you can see. And then you have this sort of tough fibrous ligament called the posterior longitudinal ligament that abuts the vertebral body. This is your posterior vertebral body, okay? So with neuraxial ultrasound, there's a little bit of lingo that I wanted to go over. One is called the posterior complex. Essentially, the ligamentum flavum, the posterior epidural space, and the posterior dura mater generally on ultrasound make up one hyperechoic line, and that's called the and we've sort of, folks have sort of termed this the posterior complex, and that's going to be the most superficial on the page. Now, anterior to the spinal cord, we have the anterior complex, so that's that includes the anterior dura mater, your anterior epidural space, your posterior longitudinal ligament, and your posterior vertebral body. And that's all sort of called the anterior complex. And the majority of it, it's a very hyperechoic structure, is made up by the posterior longitudinal ligament because it's this thick fibrous ligament. So as far as some ligaments of the spine, I think you guys are all familiar with this image. So we have, of course, our supraspinous ligament, followed by our interspinous ligament. We have our ligamentum flavum. And just abutting the vertebral body, we have our posterior longitudinal ligament. And let's hope that we never have to deal with this ligament, the anterior longitudinal ligament. So that's sort of much more anterior. We're not really going to see much of that on ultrasound. And I think it's important with the ligaments that it's important to note that the transverse process is posterior to the anterior complex. That relationship is very important. Some lumbar musculature I'm going to point out shortly here. So rector spinae, this is a horizontal section view of L3. So you're going to have your rector spinae, just anterior to that, your QL muscle, and more anterior to that, of course, is your psoas major. Okay, so how do we do this? So we're going to first position our patient, and you can do this really seated or you can do it laterally. Now, if you do it seated, if you do it laterally, it can be more challenging because of the natural curvature of the spine when you're lateral. So if you're just starting this as a new approach and practicing, I certainly would recommend starting with seated. And if you do it seated, this chair can be very helpful just to increase the forward flexion at the lumbar spine. I've found that it can really improve your acoustic window. The other way to do this, if you don't have a chair, is, if the patient can tolerate it, is to put the bed in sort of a left side down position, depending on the orientation of your operating room, to increase the flexion of the spine. So we're going to talk today about two acoustic windows. So the first is going to be the longitudinal parasagittal oblique view, and the other is going to be the transverse view. So the longitudinal parasagittal oblique view is really going to be used to identify level, so which level you want to go at, and it's also going to be used to identify depth. The transverse view is primarily used, although you can identify level with it, it's primarily used to identify depth as well as to identify midline. Okay, so when we start, we're going to start with the parasagittal oblique scan. So we're going to position our transducer about 1 to 2 centimeters lateral from the spinous process at the lower back. And as far as the position of the probe, it's going to be, we're not going to be on spinous process, so we're going to be lateral to the spinous process. So our probe position is going to be about like so. And we're going to adjust our depth. And the key here is that we really need to tilt our probe medially towards the midline, so we can really try to get a great view of some of our neuraxial structures. So our probe is going to be oblique. And the first thing we're going to do is identify sacrum. So sacrum is going to be a wavy hyperechoic structure. So here's our sacrum. And if you notice that the sacrum has a dorsal tilt, so you're going to see sort of the end of the sacrum more superficially. Here's S1, and here's our L5 lamina. And it's just worth reviewing that bony surfaces, of course, appear hyperechoic. So linear structures with dense acoustic black shadowing beneath them that obscures really any deeper structures. And connective tissues like ligaments, fascial membranes are also going to be hyperechoic. However, their acoustic impedance is less than bone. So deeper structures can still be imaged. So in this interspace, you're going to be able to see flavum, posterior and anterior complex. Fat and fluid have a low acoustic impedance, so are generally hypoechoic, so they're dark. So this is another view. Now I've just, the probe, we've just moved the probe a little bit more superior to take a closer look at this interlaminar space. So here we have the L4 lamina. And I just wanted to note that the lamina is quite sharp as far as it's almost sawtooth. Some people feel like it resembles sort of the side of like horses sort of lined up, their heads lined up, one after another. But in the lumbar area, you're definitely going to see more sharp lamina because of that slide-like look. And here you have your interlaminar space. So oftentimes the ligamentum flavum cannot be, it's very difficult to recognize it as far as distinguish it as different from our dura. But in this particular patient, we can see our ligamentum flavum as the first line, the posterior epidural space in between, and your posterior dura mater right after as a small faint line. And all of that is going to make up your posterior complex. Here you have your intrathecal space, and that's sort of uniformly hypoechoic. Sometimes you can see cauda equina, phylum terminale can be visible as sort of hyperechoic pulsatile streaks within the space. And then here you have your anterior complex, which is usually, sort of your most recognizable structure as far as very bright, makes up, of course, of all of these structures, primarily your posterior longitudinal ligament. So if your probe is too lateral, which can happen, quite easily, you're going to see what's called this camel hump sign. So if your probe is it's not oblique enough, so it's more perpendicular, or if it's too lateral, you're going to see your probe is, instead of here, your probe now is going to be here. And you're going to see a very sort of different picture. Now you're going to see this camel humps rather than those horses' heads. So much more round. If you notice that you no longer can see your flavum, your dura, posterior longitudinal ligament in this view. So it's sort of, in each hump represents the facet joint between a superior and inferior articular process of successive vertebrae. Occasionally, if a scan is very difficult, you can even be more lateral, and you're going to see what's called the trident sign. So now our probe, instead of here, which is articular process view, which is also too lateral, you're going to be out here. You're now going to see these finger-like projections, transverse process, and this is called the trident sign because you can see sort of the mythological trident, those three finger-like projections. And now you're going to see some different musculature because you're so far lateral. So you're going to see your erector spinae as you did in the prior image, but now you're going to see your psoas major muscle as well, which is deep to the transverse process. And it's important to note that all these structures are visualized within a few centimeters. So movement of the probe should be very slow and deliberate to carefully observe any pattern changes. So that was your parasagittal oblique view. We're now going to move on to the transverse scan. So we're going to rotate our probe 90 degrees to position the transducer in the transverse plane. So you're going to see your probe is going to be like so. And what we're attempting to do is put the probe right in sort of the interspinous space here. You're going to angle your probe slightly cephalad to get a better view. And here's sort of what you're going to see. This view has often been referred to as a flying bat, or it sort of resembles a flying bat. Right in here, you can see something that sort of resembles a bat, and that's what we're going to look for in the transverse scan. So when you look closely at this image, you're going to see because we are not on a spinous process, this is going to be actually interspinous ligament, because you have a direct view into the neuraxis. Here, you're going to have your articular process facet. More laterally and sort of flaring upwards, you're going to have your transverse process. And here you're going to see your posterior complex, which of course is made up of your flavum, your epidural space, and dura. Beneath that, you're going to see your CSF, your vertebral foramen. And then below this, you're going to see your anterior complex, which is quite bright. It's important to note that the transverse view, the visibility may not be as good of these structures as in the parasagittal view due to some of the limitations of the bony window and some of the scattering of the ultrasound beam. So especially in the presence of facet joint hypertrophy. And in many cases, you're not going to be able to visualize either the posterior or anterior complex, or you may just be able to visualize one. So relying on your posterior, your parasagittal oblique view is important. There's one relationship I just want to go over because, occasionally when people start using neuraxial ultrasound, occasionally the one thing on the transverse view that's often easier to see is your anterior complex rather than your posterior complex, and they can be confused. And you can get a dural puncture because you've sort of measured your depth as greater than it actually is. And if you're seeing any sort of bright line that is deeper than the transverse process, that always has to be the anterior complex, right? Just anatomically, your anterior complex is always going to be more anterior or deeper than the transverse process. So if you're seeing a line that's deeper than the transverse process, that's going to be your anterior complex, not your posterior complex. Your posterior complex is generally in the same vicinity as your transverse process, maybe a little bit more superficial. So that's a relationship that can be helpful. Okay, so if your probe is directly on a spinous process, you're going to get a dense acoustic shadow below, and you're going to see something that resembles this, like a tower. So now you're not seeing any structures that resemble structures in the neuraxial space. And if you see this, you can either, depending on what level you're interested in pursuing, you could either go up or down. So spinous process here, lamina here. Okay, so as far as how do we go about making our skin markings? So first we're going to identify the sacrum. We're going to start with the parasagittal oblique view. So we're going to identify our sacrum and our L5-S1 interlaminar space. I like to use M mode only because it gives us, or some marking on the ultrasound probe that gives a middle of the probe to make the markings a little bit easier. So you're going to center your ultrasound. You're going to just really try to get the L5-S1 interspace, the middle of it. And once it's in the middle of the screen, you're going to mark the long side of the probe. So you're going to make a mark like so. This is L5-S1. Now, as you move more cephalad, you're going to march up the spine, and you're going to see successive lamina here. And you're going to put the interlaminar space in the middle of the page, and you're going to mark it. So that's L4-5. And you're going to keep marking until you get to the desired level. You can measure depth at this level. So here we have depth of 4.41 centimeters. And interestingly, the depth in the parasagittal oblique view versus the transverse view correlate extremely well. So it's actually a really good secondary confirmation to measure depth in the parasagittal oblique view, especially because the parasagittal oblique view is going to be your easiest view, and it's always a good idea to correlate the two depths, just to make sure that you're seeing the posterior complex correctly. So once you're at the desired interspace and you've made your parasagittal oblique view, your markings, you're going to turn the probe. You're going to rotate the probe 90 degrees horizontally, and you're going to attempt to get the best interspinous view, so the bat view. And here's another interspinous view. It's a little bit of a different bat than the other patient, but here's your bat. Once you are centered, the bat is totally centered in the middle of the page, you're going to be very meticulous and make a mark at the midpoint of the long side of the probe. And sometimes I just have to make adjustments to the short end of the probe, so the horizontal line. Occasionally you have to make small adjustments to that line. And the midpoint of those two lines is going to be your entry point. It's really important when you make your entry point, though, with your needle, that you memorize the cephalad tilt and the medial lateral tilt of the probe when you make your entry point. So you absolutely can measure depth in the transverse view. So here is the caliper that's measuring depth all the way down to your ligamentum flavum / posterior complex. So just in conclusion, so compared with landmark-based approaches, neuraxial ultrasound certainly increases efficacy and precision of neuraxial blocks. And I highly recommend starting this in your practice if you haven't. It may possibly contribute to the safety of neuraxial blocks. I think we may be seeing more of that literature soon as larger studies are performed, in that it can reduce the number of attempts and associated trauma with epidurals. It can be extremely useful in identifying correct interspaces, measuring depth, and also predicting difficult placements. And it's important to understand that competency in neuraxial ultrasound is actually quite difficult to achieve. It requires repetitive, intensive training. Some studies have shown that a novice would require roughly between 25 and 40 scans to achieve a sort of greater than 90% accuracy in being able to identify intervertebral levels. However, as I think once you practice, I find that most scans take about 1 to 2 minutes and can significantly decrease actual procedure time and needle passes. So I really encourage you to practice on patients with normal anatomy prior to attempting scans on patients with really challenging anatomy, scoliosis, hardware, etc. Thank you very much for your attention.